And with that, I will introduce our speaker for today, Dr. Andrea Cruz. Dr. Cruz is an associate professor of pediatrics at the Baylor College of Medicine and the director of the Children's Tuberculosis Clinic at Texas Children's Hospital, the largest pediatric TB clinic in the United States. Dr. Cruz also serves as a pediatric consultant for the Heartland National TB Center and has been a consultant for the World Health Organization. Please welcome Dr. Cruz.
Hey guys, let's see here. I'm going to try to share my screen. There we go. And please make sure, Chelsea or Edgar, that this looks okay on your end.
It all looks good.
Yeah, okay, perfect. If at any point you guys can't hear me, please let me know. And then just let me know how it's hard for me to see the chat from the screen. And this is not a formal talk. I'm a pediatrician. We don't really do formal. So if you have questions and you want to unmute and ask questions, or if somebody from Heartland wants to keep an eye on the chat and interrupt me so we can answer questions in more real time, please feel free. Okay. So I have a couple disclosures, and then a disclaimer. The first is I'm an associate editor of pediatrics, which actually has no conflict with this talk. I do have some patient pictures. These were all sent to me by families who are very comfortable with me sharing those pictures. And lastly, I actually worked the overnight shift in the ED yesterday, so I'm taking this call from home, where I have 3 rescue dogs who are lovely. Moose is pictured there because the others don't really like taking pictures. And they sometimes like participating in Zoom calls. So they're in a different part of the house, but in case you hear barking, that would be why. So in the course of about the next hour or so, we're going to talk about several things. We're going to talk about how do we do a better job of integrating TB risk factor screening into practice, or, for those of us who do TB all the time, how do we advise others on optimal strategies on how to do this? We are going to go through the updated indications for use of tuberculin skin test versus IGRAs, particularly in the youngest children. And then we'll plan a course of therapy for a child with TB infection, which is, we've sort of had a little bit of a curveball thrown at us with rifampin shortages recently. But we'll talk about sort of what we do in our clinic and the rationale behind it. But first, I want to start with a case, because sometimes when we're talking to families, it is very, very helpful to sort of put this in context of why do I want to identify and treat children with TB infection. And I think there's a few better cases than this child. So this is a 14-month-old previously healthy little girl who came into the emergency department with seizures and just kept seizing and seizing and seizing to the point she ultimately needed to be intubated. Upon getting more history from the parents, they say that for the last 2 weeks, she's had fever and she's had some vomiting, had been seen multiple times, and had been diagnosed with gastroenteritis. After intubation, because of the seizures, she had a CT of the brain that showed prominent ventricles, areas that look like ischemia or stroke. And then after the CT, she had a lumbar puncture that had cerebrospinal fluid characteristics that were very classic for TB meningitis, with a high white count, a very high protein, and a low glucose. This is her post-intubation film. What you can see is, and it might not project as well, so she has a diffuse, what I might call a miliary pattern on her chest x-ray. And when you're looking at her head CT, there's some focal areas of infarct. You can see that there's asymmetry in the basal ganglia from one side to another. And when she had an MRI done, it actually showed really substantial leptomeningeal enhancement. Now, this child was immediately started on steroids and TB therapy and actually did quite well. And this is a picture where the family just sort of showed up in clinic one day just to come visit well after the child was off treatment. But I think this is a really illustrative case because it shows several breakdowns. This child's index case was her mother. Her mother had immigrated to this country, and mother lacked access to medical care. So the mother was actually diagnosed with cavitary pulmonary TB after the infant was diagnosed with TB meningitis. So had we had better ways to test that mother, potentially she would not have infected all of her children, because there were 6 out of 6 kids who were positive from this mom. Had we known that that child was infected, we could have provided TB infection therapy to the child and her siblings. Or even if the older kids had been tested, it would have then prompted testing in the baby. And then finally, failure to identify the early stages of TB disease, which we're not going to talk about in the course of this talk. But since TB meningitis is not that common, you can see very easily why people would attribute these symptoms to far more common diagnoses for this child. So we're going to talk about barriers to prevention, review the updated guidelines, and talk about something that I really don't need to talk about with this group, which is the importance of collaboration between clinicians and our health department colleagues. So when you think about the epidemiology, particularly of TB infection, this is now an 8-year-old study. It's hard to believe, but it's probably one of the best modeling studies for looking at the incidence of TB infection in children at the time what were the 22 high burden countries. And this number is often thrown out like 25%, 30% of the global population has TB infection. But when you try to find that reference, boy, it is hard. So for those of you who want that reference, I put it in here. And this modeling study actually included the 22 countries that account for about 80% of all TB cases, adult and pediatric, globally. And it's estimated that about 15 million children share a household with a person who has infectious TB, which means the incidence of new cases of TB infection are about 7.5 million a year, and it's estimated that about 53 million children are infected. Most of these in countries where they do not have the resources to do what we do in the US in terms of testing and treatment. One of the ways that we have tried to adapt to this in terms of US immigration guidelines is figuring out how do we do a better job with identifying both adults and kids who might benefit from preventive treatment. And so, historically what has been done was that if you were an adult, and that was defined as 15 or older, you got a chest x-ray prior to coming to the US. And if that chest x-ray was normal, nothing else happened. So there was no attempt to identify TB infection for adults or for kids. The new guidelines actually say that the old guidelines are at the top. The newer guidelines are down below, which says that if you are 2 to 14 years of age, you actually need an IGRA prior to coming to the US. A chest x-ray is needed if you were to have a positive IGRA. And it's really meant to get around the issue that, folks from high burden countries are often folks who are BCG immunized. So this is a far better modality for identifying children and adults who would benefit from preventive treatment. What about data for infection in the US? Well, it's not reported in all states, but it's estimated that about 3.1% of the US population is estimated to be infected, which works out to like 9-10 million individuals. But this burden is not evenly distributed across the population. You can see that areas that have a higher concentration of folks who are born abroad, areas that have, if you look at Alaska, for example, populations of Alaskan natives have a higher incidence of TB infection, etc. So important to keep the demographics in mind. One of the ways that this has been made far more challenging in the last 2.5 years is the COVID pandemic. This has separated many children from opportunities to see their providers, either because of loss of insurance if parents lost jobs, or family hesitancy to seek routine healthcare for their children for fear that their kids are going to acquire COVID in their pediatrician's offices. So what we noticed in 2020 was an increase in TB deaths, and this is globally, for the first time in over a decade, fewer individuals being offered preventive treatment, and then fewer referrals for TB services. It is estimated that it's actually a significant percentage of TB cases have gone undetected. And since there's quite a bit of symptom overlap with COVID, if there's mortality in those cases, oftentimes they're not in areas where you're going to have autopsy confirmation of did they have TB or do they have COVID. So why do we care about TB infection? So if TB infection, if that was the endpoint, nothing happened, the reality is we probably wouldn't care. But we know that the risk of progression from TB infection to disease really hinges on 2 factors. The first is the age at which a child is infected, and the second is their immune status. So as a pediatrician, I very much focus on the age of infection only because the vast majority of the children that I see are actually pretty healthy kids. And that's not going to be the case for those of you who are taking care of adults. So when we think about who is at high risk for progression from TB infection to disease, we often focus on those immunocompromised patients, and certainly those patients' risk is high. There is no person on the planet whose risk is higher than an infant in the first month of life. We know that if those infants are infected and we opt to do nothing, or we simply don't know that they're infected, we know about half of those kids will progress to disease. As concerningly, we know that the risk of having dissemination outside of the lungs is incredibly high, and up to 20% of infants infected in the first year of life who progress to disease will actually have TB meningitis. And that case that I presented at the beginning of the talk aside, most of my children with TB meningitis, unfortunately, do not do nearly as well as that child did. And there are not a lot of pathogens that'll take a normal kid, and make them pretty neurologically devastated with the rapidity that tuberculosis does. As children get older, kind of you have a decreased risk of progression from infection to disease. And that risk decreases and it naters out sort of in the elementary school years. So if you get infected during elementary school, that's called the golden period of childhood TB, because for reasons we don't understand, you're at lowest risk of progression to disease if you're infected as an elementary school kid. And then you hit adolescence. And as the case with many things, the wheels kind of come off the bus, the rate goes up higher. And interestingly, it actually goes up higher in adolescent girls than it does in adolescent boys. We don't really know why that's the case, but one of my colleagues at Brown University is trying to study just that question. And then the issue with the adolescents is not just that they're at higher risk of developing disease, but they're more at risk for developing adult type disease, namely cavitary disease. And so it has a much greater public health impact than the diagnosis of pulmonary TB in a younger child. And when we think about how did high incidence countries become low incidence countries, I mean, I think the perfect example is the US, right? I mean, before the advent of tuberculosis or of INH, the rates, had been declining somewhat, even declined in the early part of the Great Depression. And that's thought to be due to changes in nutritional status and maybe changes in ventilation, that maybe tenements had slightly better ventilation, so there was less transmission. And then you see that spike. You see that spike in the early 1940s. And that spike in the 1940s is because when men were drafted for World War II or when they volunteered for service, part of their screening was a chest x-ray. So you had all these folks who might or might not have had pulmonary TB, nonetheless had abnormal x-rays. They were excluded from military service, but that's what led to that uptick. And then the rate sort of steadily progressed down, but it's really not until the late 1960s that the US became a low incidence TB country by our own definition, which is less than 20 cases per 100,000. And what was this? What got us there? INH got us there. And this is going to be ironic because I'm about to poo-poo INH when I talk about different regimens, but INH is really what got us there. So why do we have a problem with this? Here we have a disease that, by and large is very preventable, but there are a lot of barriers that our families face for treatment. So first is failure to identify who needs testing. And the important thing here is that in the days where we had universal skin testing, and I'm by no means advocating for this, but when we had universal testing, the expectation was that kids would get tested at their pediatrician's office when they came in for well child visits. But if you lack a medical home, there's not a way that you're really going to get picked up unless the health department comes knocking on your door to say, hey, by the way, your kid just got exposed to Johnny, who has cavitary TB. There's a failure to use the AAP risk factor questionnaire, which we'll go over, which actually really tries to streamline things and ask just 4 questions to identify who needs to be tested. So one potential solution for this, since we have so many children who lack health insurance, is thinking about how do we do screening in non-traditional settings? Is this, screening for risk factors in schools, at health fairs that are conducted by different community groups, etc. The second is the failure to test appropriate. I'm going to provide you with some data on the very slow uptake that we've had for interferon gamma release assays and the challenges that we have with tuberculin skin test misinterpretation. And I'm not talking about TST misinterpretation when it's done by my friends at the City of Houston. I'm talking about when TSTs are read by somebody who might read a tuberculin skin test once every couple years. And the solution to this is obviously IGRAs. Here you have a laboratory-based test that doesn't require the family to come back and requires just one face-to-face encounter for testing and conveying those results. Another challenge that I've noticed in many of our families is failure to explain the reasons for therapy. And sometimes, you'll have a family who's born and raised abroad, and they might have been told at some point in their life, your child's TB test will always be positive because you received the BCG vaccine. And if you fail to address that prophylactically, it is very challenging then to convince a family who gets on Google and Google's isoniazid and reads that if you're a 95-year-old alcoholic with Hep C, you don't do well with INH. They do not want to give that drug to their baby. So it's important to talk to them about IGRAs and not having cross-reaction with BCG vaccine. And also there's a lack of emphasis of TB infection treatment internationally. So again, we have to address that up front because this is a paradigm shift for our families. We spent a lot of time at the first visit, giving information to families, giving information packets, really trying to sell them on this, because if they're not sold on this at the time of the first visit, you're just not going to see them again. And Chelsea talked about this at the beginning of the talk, but the resources on the Heartland website are absolutely amazing, and they're in so many different languages, and it's a very lovely resource to be able to offer families. And it needs to be pediatric specific resources that you offer. Otherwise, parents are going to Google this and just freak themselves out about the hepatotoxicity. And then I think the last thing is failure to anticipate barriers to therapy. So you are telling a parent of, after you just tell them, congratulations, your kid's chest x-ray is normal and they have a normal exam and they have no symptoms. And we would like you to give them anywhere from a 3 to a 9-month course of therapy in an asymptomatic child, right? Got to explain the rationale behind it. And I use de-identified patient examples to indicate this case. So you can try to reason with families. You can try to use logic with families. You can also try to make families feel badly if they don't give kids treatment, because of the possibility of the kid progressing to disease later on. And then lastly, you got to make it easy for families. I think about all the ways that things can go sideways for families if they have just arrived from another country. If I give them a script for a medication, what does that imply? What is the gap between me giving that script to the family and a pill going into that kid's mouth or a liquid going into that kid's mouth? It means the family has to take the medicine to the pharmacy, has to be able to return to the pharmacy and pick it up, has to be able to pay for it, has to have sufficient levels of social stability that the kid is getting the medication, and the family needs to be cognizant of what it takes to monitor those children for side effects. Because the reality is, we're not going to be seeing that kid on a weekly basis. We can get around all of these barriers by use of directly observed therapy. And when I talk to families about DOT, very, very rarely do I get pushback from it. I present it as, this is a way for you to have an uninterrupted stream of medications for your child that you do not have to pay for, and somebody is monitoring them to make sure that everything is okay. And if you present it that way, there are very few parents who are going to be like, I'm not interested in the free medicine and monitoring. So you want to make it easy for families. So what we're going to talk about in the course of the next little bit are the portions that are in red on this slide. So how do we screen for TB risk factors? So who does the American Academy of Pediatrics recommend testing? Right. So it's probably been 20 years since universal testing by skin testing or IGRAs. Well, IGRAs weren't around when the recommendations were made, but it's been probably about 20 years since the recommendation changed away from universal testing. So an initial IGRA or PPD should be done, or both, should be done before the initiation of any immunosuppressive therapy. And this includes chemotherapy. That has made little traction into the oncology population, but chemo is pretty darn immunosuppressant. The GI guys and the rheumatology folks are amazing at this, and they are very, very proactive with testing their patients on the pediatric side. Annual tests should be done on kids who are incarcerated or HIV infected, and every 2 to 3 year testing should be done in children who have other high risk factors, and we'll talk about what those are momentarily. And then obviously immediate testing should be done as part of a contact investigation if they have symptoms concerning for TB in children immigrating from endemic countries. And when I think about, what are considered high incidence countries from a TB standpoint, it's actually way easier to remind people of the regions that are considered to be low risk. So low risk is US and Canada, Australia and New Zealand, and Northern and Western Europe. Everything else is considered high risk. So my other sort of cheat sheet for that is, if I think about, do I need to get travel vaccines before I go to a place? That's probably a place that is also high burden for tuberculosis. So this is a TB risk factor questionnaire. There are some overlap between the questions, because if you receive the BCG vaccine, more often than not, you were born abroad. But basically, were you born abroad or lived abroad? Do you have a family member with a history of TB or TB infection? And that's pretty much it. Those cover all the questions. If you just have one positive, it's not particularly specific for TB. If you have a number of them that are positive, it's quite specific, but then you take a ding in terms of your sensitivity. So, you do a TB questionnaire with a family and they say, yes, we just arrived from Colombia, and Colombia is on the list of high burden countries. So then what do? So we in Houston were very early adopters of interferon gamma release assays because we immediately recognized the potential that offers for our children who've received BCG vaccine. So we actually did a survey, and this is a couple years ago, looking at the Emerging Infection Network, which is a network of North American, predominantly US and Canadian pediatric infectious disease specialists. There were we actually got a pretty decent response rate. A couple things that became quite quickly evident. The first is that even among pediatric infectious disease providers, there wasn't that much experience with TB infection or TB disease. And this is really important because the first call that a clinician will often make when they have a question about TB is actually to the local pediatric infectious disease person. And I would say that this is a plug for Heartland, right? Heartland folks do this all the time. And if you have a complicated kid, I think it's a very legitimate question to say, how comfortable are you to your specialist in terms of taking care of this child? And if they've never done this before, and it's a kid with TB meningitis, that's when you got to pick up the phone and talk to Lisa Armitage. Secondly, there was substantial variation in IGRA frequency in terms of had people ever used it at all or how often they used it. So it was used very infrequently, and particularly in the preschool age kid where almost everybody continued to use the TB skin test. Lastly, the vast majority of folks were still clinging to use of INH as first-line therapy. And when we submitted this to the first submission venue, I got an email from the editor of the journal, and he said, Andrew, we can't publish this. It makes it look like we don't know anything about tuberculosis. And I'm like, because y'all don't. So again, really important because I think that all of us on this call have a really important role in advocating for education of the clinicians in our community who realistically might not be seeing these patients with much frequency. They're going to be seeing kids who have a host of other conditions with way more frequency than they're going to be seeing our patients. So, we need to feel comfortable in our role as educators and advocates for these kids. One of the things when IGRAs first came out was there was concern about possible, like a bunch of indeterminate results. And this was certainly present in some of the early studies. We actually looked at this in our center because we thought we were having an exceedingly high rate of indeterminates. And we realized they were almost all coming from the inpatient side. And even after we controlled for immunosuppression, we controlled for other factors, it was still there. And what we realized was we had actually educated the phlebotomist in our outpatient lab because it's in the same building as our clinic. So they knew how to process the samples. They know you just don't put the blood in the quantiferon tube, for example, but you got to shake it. And those tubes need to look frothy, like frankly, the head of a beer that's been poorly poured. And that education had not been rolled out on the inpatient side because the inpatient side was such a sprawling place. And the phlebotomist in our outpatient lab were a very contained unit. So what we did was, instead of trying to educate folks on it, we actually got these obnoxiously fluorescent colored flyers, and we put them around the packet that had the quantiferon tubes. So you had to actually, look at the thing before you tore open the tube, and it had the instructions on processing. And with that, we dropped our indeterminate rate to almost 0. So when we think about an algorithmic approach to TB testing, again, this is not geared for health departments in mind for this algorithm, because this is stuff that you guys know. But if there are ways that you can use this to educate folks in your community, by all means, we want to disseminate this. So, first is ask about TB risk factors. If they got no TB risk factors and they have no symptoms, you stop. There's no need to, to go down an unnecessary pathway. If they do have risk factors, then you do a test for TB infection. And so I'm going to take a step back. What are those risk factors? Again, what we covered. So the epidemiological risk factors that are on the AAP questionnaire, or medical risk factors. If you are infected, what are conditions that predispose you to developing TB? And those would be, obviously, the kids are HIV infected, our children with other reasons for immunocompromise, including our diabetic patients, right? Recognize that the link between TB and diabetes is so well recognized on the adult side, it is relatively under-recognized on the pediatric side. So if they have those risk factors, you do a test for TB infection. Sometimes you're going to do more than one test for TB infection. And that's going to be in the kids you're worried that they might have disease, in the kids who are incredibly immunocompromised, who you think, let me do both tests, and if either test is positive, I'm going to offer them treatment. And rheumatologists sometimes do that. If the test is negative, you stop. If the test is positive, get a 2-view chest x-ray. And if that x-ray is negative, we can talk about treatment for TB infection. And I try to do this all once they refer to me, I don't send them away for x-ray and then see them back. They go to x-ray first and then they come see me, because then we can have a more nuanced conversation about treatment plans. We'll talk about the different regimens that we use and why we use them. And then if the chest x-ray is positive, again, unless you're accustomed to taking care of kids with TB disease, and if you don't have folks in your community who are comfortable with that, that's why you need to reach out and phone a friend, right? That's why Heartland is here. When we think about skin tests and IGRAs, there are many advantages to IGRAs, and I touched on some of them already. Decreased risk of cross-reaction with the BCG vaccine, decreased cross-reaction with other non-tuberculous mycobacterial infections. And, please remember, little kids put stuff in their mouths that's not food. I know not your kids when they were little, but other little kids, right? Like my nephews put all kinds of garbage in their mouth when they were little. And along with that soil, there's non-tuberculous mycobacterial infections. So you decrease the rate of false positives really dramatically, both from BCG and non-tuberculous species, by use of IGRAs rather than a TB skin test. What does this do? It doesn't really do much for your sensitivity, but it does a lot in terms of increasing your specificity. Obviously, neither test helps you distinguish between infection and disease, but one advantage to IGRAs, particularly in populations who might be being tested with some frequency, OSHA requirements, for example, then you have no risk of boosting because all the tests are done external to the patient. And one thing I think sometimes we don't think about as often is the number of patient visits required, right? So TB skin test might be cheap, but if you have a lot of false positives, you have a lot of people not coming back for treatment, you have a lot of people, and I think of, I'm going to use the example of a female pediatric resident. So if she has a positive tuberculin skin test, several things happen, right? First thing that happens is she has to get a chest x-ray. Well, she's a 26-year-old woman. You ain't getting a chest x-ray until you get a urine pregnancy test. And many times, in adults, since they don't tolerate their medication as well as children do, people want to get baseline LFTs. So that's a lot of cost to the system in, a person who might be from, a very affluent area where their likelihood that this is actually TB is quite low. We also know that, not among my pediatric residents, because frankly, they're somewhat of a captive audience, but we know that for our average kid in the community, somewhere between 20 and 25% of kids do not come back for skin test interpretation. What does that result in? That results in another skin test being placed. And then it leads to this cycle where you have an increased risk of boosting. So with IGRAs, again, you just have one face-to-face encounter with a family. Yes, you still got to call them and tell them the results, but they don't need to come in 48 to 72 hours later. I admit that skin tests to some degree have become a bit the bane of my existence, but I have a very biased perspective on this because I get a lot of kids who are referred to us where the skin test is simply listed as positive. I don't know what to make of a positive test unless that test is a urine pregnancy test, where then I'm pretty sure I know what to make of that test. So the fact that this is not a nuanced test, we know there is a lot of variation in person to person reading this test. And the reality is when you're talking about a 9mm skin test meaning one thing and a 10mm skin test meaning something else, how confident are you in your ability to distinguish between 1mm? And I might need reading glasses, but I think that my ability to distinguish between 9 and 10mm has probably declined over the years. So, this is something that I think we have to be cognizant of. The other thing we have to be cognizant of is, we use a sliding scale for tuberculin skin tests because we want to optimize the sensitivity in high-risk patients and optimize the specificity in patients who don't have risk factors. So what do? It's almost like we spot kids' points, and we don't make you be quite as positive to be considered positive if you have risk factors, either epidemiological risk factors like, oh, grandma just got diagnosed with TB, or if you're a poor host, or if we think you have TB disease, because we know that makes you allergic. In contrast, the kid who was, born and raised in Iowa, nothing against Iowans, they just don't have as much TB as we have in Houston. If they have a positive, the likelihood that it's from TB is low. So what we want to do is we want to make you be really positive before we consider you positive. This makes sense when you talk about in philosophical terms. It becomes very challenging for people to operationalize this, especially when they don't do this with the frequency that we do. So again, you get around those issues with using IGRAs. You also get around a lot of the other limitations for skin tests, such as the false positives, some of the false negatives. Some of these are going to be cause falsely negative IGRAs too. right? If you have a kid with Crohn's disease who's getting their first test of infection after they're already on 4 immunosuppressants, you should not have a great deal of faith that that skin test is truly negative. So how have the guidelines changed? So, the guidelines always lag behind the literature, right? And my friend Jeff Stark always says that watching the creation of guidelines is kind of like watching the creation of sausage. You might like the output, but you probably don't want to watch the actual process. And guidelines are very similar. So the most recent guidelines, which were updated last year, actually say that the tuberculin skin test is recommended still for kids less than 2, but IGRAs are acceptable. And this is actually a shift into being more permissive for IGRA use for our youngest children. The guidelines still say that IGRA is the preferred test for BCG immunized children, and that all tests should be used cautiously in children who are immunocompromised because of the risk of false positivity or false negativity. And I'll use an example. We had a child with chronic kidney disease who was on systemic steroids. Mother was diagnosed with pulmonary TB. Kid had 9 siblings. 8 of the 9 siblings were positive. The only one who was negative was the kid who was on steroids. I treated that kid as though they were infected. I thought it would highly unlikely that the mother would not particularly baby her only chronically ill child. So I looked at the epidemiology of all the siblings. Unfortunately, that's when it's great when somebody has a huge sprawling family, right? They only had 1 kid, you'd be like, don't really know what to make of this. But that little kid got treated for a full course of treatment. So what do we use to treat? So first, before we talk about treatment, you got to make sure the kids don't have TB disease, right? Because that's the cardinal sin of tuberculosis, is treating them for infection when they in fact have disease. Because the reality is we don't have that many TB meds, and if we don't use them judiciously, we do poorly by our patients, right? So what does that mean in the pediatric population? I always get 2-view chest X-rays, and the reason to get a 2-view chest X-ray is particularly important in our preschool age children. They will have a big thymic silhouette, and it is hard to see through the thymus to be able to exclude do they have hilar or mediastinal lymphadenopathy. If you get a lateral film, thymus is very anterior, so you can totally see any nodes that might be hiding behind the thymus. We look at the growth curve. This is a challenge if the kid, it has never been seen in your system before, but if they have, and they've been, slowly chugging along in their weight curve, and all of a sudden they plateau on their weight curve, or they have weight loss. And I will say that weight plateauing is way more common in this country than necessarily weight loss. Loss of developmental milestones, particularly if you're concerned that they have TB meningitis. And then one thing in the pediatric population that's hard, the second most common site of disease after intrathoracic is lymphatic, right? And sometimes you take your average, I think of my 5-year-old nephew, and Miles has little tiny nodes in his neck, and they are nothing. And so what I tell the residents is, if you feel those nodes and you wouldn't pay any attention to them if you were in the emergency department or you were in your primary care clinic, you should not pay attention to those nodes. If you fail to pay attention to the nodes of the child who's on this slide, something is wrong. Okay, so this kid had TB culture from both of those nodes. And so remember, if you get a chest X-ray and you do a good lymph node exam, and the kid is otherwise asymptomatic, right? TB meningitis, not asymptomatic. Bone and joint TB, not asymptomatic. Genitourinary TB, an adult problem typically. And peritoneal TB, they're going to have belly pain. So if you get chest X-ray, good lymph node exam, no symptoms, the likelihood you're going to miss a child with TB disease is very low. And this is an example of weight stasis in one of my patients. So this is a kid who, was chugging along very well, we think, until he was 12 and a couple months. And then you notice that this kid went about 3 years without gaining any weight, or 2 years without gaining any weight. He was diagnosed when he was 15. We started him on treatment, and then he rebounded his growth curve. So we are, of the things that I pay attention to most in clinic, yes, we take vital signs on all of our children, but I look at their weights and compare their weights at the current visit to their weight at the last visit at every single growth curve. Because sometimes while kids tolerate TB medicines very well, sometimes the first symptoms of drug intolerance in a child is that they've lost weight, especially in your preverbal kids. So if they've lost weight and there's not a good reason for it, it's not like mom said, well, last time when he was weighed, he had a ginormous poopy diaper, and this time he had a clean diaper. So, your weight from last time was like poop weight plus kid weight, and your weight this time is just kid weight. Sometimes there are obvious explanations like that, or they were weighed with shoes on one visit and without shoes the next visit. But if you see a weight stasis or weight decline, that should raise red flags for you. So what are the TB treatment regimens? So we've actually evolved dramatically as a subspecialty in the last 6 years in this regard. So back in 2015, the recommendation said you should use INH unless you have a compelling reason to use something else. And what were those compelling reasons? Source case had INH resistance. The kid was on some seizure medications that precluded you from using isoniazid, or the kid didn't tolerate INH. And then it said, under those very grudging circumstances, you can use rifampin. And we said you could use 3-HP, but only in kids who are 12 and above, because at the time we actually did not have any data on the appropriate dosing for younger children. Between the 2015 and the 2018 recommendations, there was a lot more data that became available on INH and rifapentine. Jeff Stark was instrumental in the changing of these guidelines. And while they listed no specific preference, the order in which they were in the Red Book, Jeff was clearly trying to send subliminal messages about what you should be using. And it started with using INH and rifapentine, then down to 4 months of rifampin. And then as the third tier option, although it wasn't a tiered strategy, was isoniazid. So really expanded the role of rifampin, dropped the age for using INH down to 2 years of age because we had pharmacokinetic data down to that age. I will say, and we'll talk more about INH and rifapentine, the pill burden is hard for some little kids. So I give parents options in terms of the regimens. I said, do you want to fight with your kid 1 day a week, or do you want to fight with your kid on a daily basis? And usually the parents decide that employing mixed martial arts maneuvers on a weekly basis is preferable to struggling with their child on a daily basis. But I present all the options to them, and then I say, look, if for my kid, this is what I would do, but these are your options. The 2021 recommendations say that several regimens are recommended, and a lot of it depends on the circumstance. So it says, 3 months of 3-HP, 4 months of rifampin, which obviously right now is challenging given the national shortage. It actually included 3 months of INH and rifampin for the first time, and that's given on a daily basis. It did say if the caveat of rifampin or INH and rifapentine were unavailable. And then it said 6 to 9 months of INH. And the US studies actually indicate you get probably a 20 to 30% benefit by giving 9 months over 6 months. And that's based on trials from the 1950s. But there's not really a reason to think that that has substantively changed. But since the international guidelines are 6 months, then if a kid's gotten at least 6 months, then you can call it a day and say that child has been treated. And the updated guidelines, it really didn't change the role of rifampin, although it did talk about changes in rifampin dosing, which we'll get to for the day that we can use rifampin again in the future. So why is this important? So, we know that the vast majority of peds ID people, 6 years ago, really almost exclusively relied on INH. We also know that adherence with INH in several pediatric and adult studies is less than 50%. And sometimes people think, well, I know that patient didn't actually take the INH for themselves, but surely they'll give it to their child. And that's somewhat of a ludicrous proposition to think about, right? So just because we've been using something for a long time doesn't mean we need to continue to use it if there are better options that are available. And frankly, the options, and we'll talk about them, are just as efficacious, are just as safe, and is a lot easier for families. So when we thought about this, we actually looked back on our patients in terms of adherence with TB infection treatment. And I will be honest, the reason Jeff and I did the study was that we were concerned that we were doing a good job with our English and Spanish speakers. And we were worried that maybe, no pun intended, something was lost in translation when we were having to go through a phone translator or something else. So from an equity standpoint, we wanted to make sure that we were providing, equitable care across the wonderful demographics of the kids that we care for. And what we actually found, is that the things so there were no demographic characteristics that are associated with completion of therapy. And this is important because there had been some studies that had come out showing that there is differential adherence with treatment and completion rates based on kids' racial and ethnic backgrounds. Okay, so we found zero evidence of that. It didn't matter where you were born. It didn't matter what language you spoke. Two things mattered. Did you get a short regimen? And who gave you the medications? So if you got a short regimen and the health department helped with administration of that regimen, those things were far more important than any other variable in demonstrating success of that child completing therapy. when we looked at, this is a study actually that was by Dick Menzies and colleagues in Canada that actually looked at 4 months of rifampin versus 9 months of INH. And this was really important because for a long time, while rifampin had been well documented to be an effective form of therapy for adults, because there wasn't specific pediatric data, people were reluctant to use it. And I think this is reflected in some of those early guidelines that I showed you. So this study is really important because the reality is, as pediatricians, a lot of times children are not included in the original studies. The people who are included are adults. And as pediatricians, we're left to extrapolate adult data and figure out how can we use this to take better care of our kids. And the reality is that everything that has been done and been shown to be successful for TB in adults also works for kids. And it's sort of illogical to think that rifampin wouldn't work, assuming that we have the dose correct. And what they found was there was no hepatotoxicity in either arm of the study. The only disease was seen in the INH arm. And it's important, this was not powered for efficacy. This was powered for safety. And very, very safe. And actually, when you talk to our liver doctors, they far prefer their kids being on rifampin than isoniazid because they view it as more hepatogentle in the pediatric population. When we looked at how likely were people to complete therapy, and this was not randomized. We went back and we looked at our patient population, and so it's subject to all the limitations that you might anticipate from a retrospective study. But what we found was if you got rifampin via self-meds versus INH via self-meds, so we gave you a script and you went and filled it, you were 8 times higher to complete therapy if you got rifampin. Again, this should not be a shock, right? People do better completing treatment if they don't have to take it as long. People are more likely to finish a Z-Pak because it's once a day for 5 days than they are to finish, a long course of therapy for sinusitis where they're on Augmentin for 14 days and it gives them diarrhea, right? So, but also when we compared rifampin via self-medication to isoniazid administered under direct observation, there was actually no difference between the groups. And this is really important because I admit to having the luxury in Houston of having several health departments that are able to go out and deliver medications to my patients. The reality is that's not the case everywhere, right? And some families might be like, not interested in having the health department folks come out for reasons of stigma or whatnot. So if that's the case, once rifampin becomes more readily available, remember that this is a very nice option that families tolerate very well, although you really do have to warn them about the orange urine. If you fail to warn them about the orange urine, the gates of hell will open on you. So what about isoniazid and rifapentine in kids? So this is the pediatric arm of the adult trial being originally published in New England Journal. And the adult trial actually included kids 12 and above, but this pediatric trial specifically carved out what is standardly considered to be the pediatric age range. And so what they found was the rates of treatment completion were significantly higher with INH and rifapentine. There was no difference in discontinuation due to an adverse effect, and no kid had hepatotoxicity. So it's important to think about why we use 3-HP. It's not because it's necessarily safer, although actually some of the data suggests that it is safer. It's because it's easier for families, and it gets the kids on and off treatment easier. And the way I explain to families, I say, look, if you Google the individual medicines, yes, you're going to come up with, that both are potentially hepatotoxic. But the data in adults actually showed that the rate of hepatotoxicity was substantially lower with INH and rifapentine, probably because the patients weren't receiving medication as long. So their exposure windows were far shorter than they were for other regimens. So we looked at this in the first 80 kids that we treated because, again, we recognized we had done the earlier study looking at the poor rates of INH adherence. So when 3-HP came out, we jumped all over it because we figured you got to get higher than 50% adherence. 25 of the kids were less than 12 years of age. So it was, outside protocol at that time or outside the national guidelines. The vast majority of kids completed therapy. One kid had some right upper quadrant pain with some transaminase elevation that resolved. And one adolescent actually developed cavitary TB 7 months later. And I'll admit that caused me palpitations because we just don't have that many kids who we treat for infection who recrudesce with disease. And when I pulled the kid aside from her family and I said, I'm really worried that you have multi-drug resistant TB and, are you sure you took your medicines? Then, the kid admitted to cheeking the pills and spitting them out after the DOT worker left. And, she was a 17-year-old kid. There's only so much we can do to support our patients if they are if they're going to those extremes to not take medications. But it did make me feel better because I was like, wow, one, treatment failure in a relatively small cohort of kids, when we just don't see that much treatment failure, admittedly totally made me anxious. When we looked again retrospectively at our patients, we looked at all the different regimens we use. We only give INH rifapentine under direct observation. That might change in the future. Right now, I think it's incredibly challenging, having spent time in sub-Saharan Africa, where the first time I went, I took a weekly malarial prophylaxis, and I ended up with a lot more pills in the bottle when I came home than I should have. And then I realized my adherence was definitely not what it should have been. And it's because we're just not accustomed to taking medicines on a weekly basis. So we still use 3-HP under direct observation. But you can see the completion rates were incredibly high for both 3-HP and for rifapentine, on the order of being somewhere between 27 and 31 times higher completion percentage than INH administered by families. So again, if you're reaching for INH, you gotta ask yourself, why am I doing this? We have noticed over time that our rates, the way that we diagnose kids has changed. And this, these are slightly dated data right now. Sorry for that awkward alliteration. Whereas at the beginning of the study period, about 60% of our kids with infection were diagnosed by skin tests. That had really dropped to about 40% by the end of the study period. And then we had a number of kids who had both a skin test and an IGRA. And sometimes, that reflects the fact that a kid got a skin test. I look at the kid and I'm like, I would have gotten an IGRA in you had I been seeing you initially. And I didn't necessarily want to feel hamstrung by the decisions that had been made before. We do an IGRA, and the IGRA is positive. And they're like, well, now we got, 2 nails in the coffin in terms of needing treatment. Similarly, over time, you can see, again, we were very early adopters of INH and rifapentine. We also had expanded, before the shortage, rifampin usage. So really, by the end of the study period, we only had about 5% of our kids on INH, or 8% of the kids. And those kids, they had good reasons for being on INH. The most common reason being that they were medically complex kids who were on other medications that interacted with isoniazid, or with rifampin, excuse me. So we were quote unquote stuck using isoniazid, and the kid taking a 9-month course of therapy because they had so many drug interactions that modifying the dose of all their immunosuppressives, all their antihypertensives or whatever was simply impractical. But again, that's a conversation you have with the families. And it's important, if they're going to educate themselves about other regimens, that they know why you selected a longer regimen for their child in particular. So why don't we use more rifampin? Well, now it's easy because of the national shortage. One thing to take into consideration is, and there's quite a bit of variation from state to state, so it might be quite different in the areas in which you live and practice. But in the Texas area, the only way we have for getting meds for kids without the parents paying for it is either under DOT or under something called ESAT, which is enhanced self-administered therapy. So for ESAT, the health department drops off medications, will visit periodically, but will call more frequently, but they're not the ones directly administering the medications. It takes barriers of, can you afford the medicine? Can you get transfer or transportation to the pharmacy? Can you pick up refills? Gets all those barriers off the table. If there is social chaos in a home, enhanced self-administered therapy is not going to cut it. If the kid spends, time at 5 different homes during the week, it is going to be challenging for the parents to remember to take that medicine to all the places that Johnny goes. So that's, this is a plug for using directly observed therapy whenever you can. It's also hard to get the suspension form, and it's got a relatively short half-life, and not all health departments can extemporaneously compound it. So sometimes they have to send it to compounding pharmacies. Rifampin is a great drug. The dose, these are just things you have to consider before you just hand families scripts for something. We used a lot more rifampin before the national shortage came out. It is important if you're using rifampin that you're aware that there are increased dosing guidelines in the most recent pediatric TB guidelines. And the reasoning for this is we know that children typically metabolize TB medications far faster than adults do. So what you want to do is they sometimes will need a higher dose to account for the intrapatient variation in drug dosing. The reality is, if you provide a higher dose to compensate for a child metabolizing the medicine, there are no higher risk of side effects. And I'm not talking an intentional overdose or an accidental overdose. I'm talking the kid gets the dose for which they were written. So again, if you're reaching for INH as your first line treatment, you should be asking yourself, why am I doing this? Is there a compelling reason that they cannot get a rifamycin-based regimen? If it's because right now we have a rifampin shortage and the kid is 8 months of age, then that's a good reason to give that kid INH. If the parents don't want directly observed therapy and they can't afford rifampin, that's a good reason to give INH. It's on the Walmart $4 plan. Important to have conversations with your parents or your patients, your adolescent patients, with the parents out of the room about concomitant substance abuse. So I have this whole conversation that I like, I can do in my sleep with my adolescents, and I kick the parents out of the room and I'm like, dude, you cannot do these things. And if the kid's like, oh, I do this, this, and this, then frankly, you got to guide them on what's going to be more or less harmful for them while they're taking TB medicine. So this is like this amazing email I got from one of my patients who had a vague recollection that he wasn't supposed to drink and he wanted to know if he could smoke pot. So he sends me this email. I don't know how he thought I was going to answer the question. Do you think I was going to put in electronic format that smoking pot is less harmful to him than drinking alcohol when he's on pulmonary TB meds? So I'm like, call me, was my response. And then we had a conversation about what would be more or less harmful. This is a text that I got from one of my patients, and I realized that as a woman in her mid-40s, my name recognition of street drugs is suboptimal. So I learn a lot from my patients because I end up Googling when they tell me stuff like, what if you're taking pills for, I love it, the TB, and you do drugs like lean and dro just once? And I looked at this text and I said, I have no earthly idea what those things are. So I Googled it, and dro is hydroponically grown pot, and lean is a combination that sounds absolutely nauseating. That is Phenergan, codeine, Sprite, and Jolly Ranchers. Now you got to wonder that they must have had some other substance on board when they decided this was a good combo of stuff to take. But again, you got to have this conversation with the kids. And I usually preface it with, this is a conversation that I have with all of my patients who are 10 and above. And then, that destigmatizes it. I don't want my patients to think that I'm specifically targeting some of my patients for this conversation and not other patients. So couple caveats, because I want to leave plenty of time for questions in the panel. The first is, when a child is having problems with TB medication, the issue is often the parents, and it's often buying into the need for treatment. It is important that you identify who is the decision maker in a family. So if you have a teenage mom who's there with her baby and grandma's in the room, you do that child a disservice by not looping grandma into all the communications. Because you can be almost assured that if mom's like, oh yeah, and then you haven't looped grandma on, and they get in the car and grandma's like, what did she say? We're not doing that. Then that child is not getting meds, right? Secondly, INH suspension, not the ones that we get from our local health departments, but the commercially available ones that you can get at Walmart and CVS, they are sorbitol based. So when kids take that, they usually take it without problem because it's quite sweet. But those starches hit the large bowel and they suck in water, and the kids have like blowout diarrhea. And again, if you have an asymptomatic child, if they have any side effects, the parents might very well say, risk benefit wise, this doesn't make any sense. And there's nothing like getting explosively pooped upon by your child to make you potentially reevaluate the benefits of treatment. So I explain to parents, hey, you know what? I'm going to write you for pills. Do you think it's because I think that your 14-month-old child can swallow pills? No. I said, I want you to crush the pills and mix it with something the kid likes to eat, because that gets you around the diarrhea. I do not get baseline LFTs in otherwise healthy children. If they are in other medicines that are hepatically metabolized, I think of my patients with epilepsy, because most anti-epileptics are hepatically metabolized, then yes, I get baseline LFTs. I also get them in my obese patients, because we know that even in the pediatric population, a significant percentage of morbidly obese children will have bumps in their transaminases because they have non-alcoholic fatty liver disease. Does this change my decision to treat them? No, it does not. Because the reality is, those are the kids who are going to grow up and be diabetic. I really want to make sure we treat them well so that they don't become, Lisa and Barbara Seaworth's problem when they're, 50-year-old diabetics who have, a hemoglobin A1C of 15, right? But I need to know if they have baseline LFT elevation, because let's say you give them rifampin when it becomes available again, and they, and then they complain of belly pain, and you're pretty sure it's constipation because they're like a pebble pooper and they poop once every 2 weeks. But you get these LFTs and you're kind of like, oh crud, my AST's 90 and my ALT's 100. All of a sudden, You have a kid who's got a bump in their LFTs with symptoms. You don't want to stop therapy unnecessarily in those children. So that's why I get LFTs in those kids. What I tell parents is if you suspect that the child is having any problems taking the medicines, stop the medicines first and then call me. I work shifts in the emergency department. I'm sometimes sleeping at weird hours. I don't want a parent to call me. It takes me a day to get back to them. Kids having side effects from their meds, and the parents chugging through and continue to give meds to that kid, right? I want them to stop until we have a chance to talk. And then, if necessary, we check LFTs. So in conclusion, IGRAs can identify children who are going to receive the most benefit from treatment. It's going to reduce unnecessary treatment in certain populations. There are things that are external to patients that we can do to optimize success for our patients. A lot of times when patients don't have success with treatment, we have a tendency sometimes as providers to put the onus back on the family. But I think we need to realize that there are things that we can do to make our parents' lives a lot easier. I actually put my info down here. All the Heartland people have all my info as well. So if you guys have questions, just put something about the TB in the subject line so it doesn't end up in my junk folder. But we are here to help you guys when you have questions. And another take-home message is I had latent TB and received treatment when I was a med student. And for me, that was like, I was a healthy young person. And for me, I was like, oh my God, that was like pretty high on my problem list, right? For some of our families, they have a lot of other stuff going on, and it might not be on their top 5 problem list. So again, important to anticipate barriers to care. If you sense hesitancy from the family when they're in front of you, dive in and try to explore that. Because if they're hesitant in front of you, the likelihood that they're going to be even more hesitant when they're not in your presence is really quite high. Feel comfortable phoning a friend, right? We do this because we want to prevent the images in the bottom part of the slide. This is Jack. Jack is beautiful. I admit to having a total crush on my 2-year-old patient. And Jack had a miliary TB. He actually had multiple tuberculomas that you can see here. And his mother actually became an advocate for TB prevention and actually spoke in the United Nations. And so this is Jack behind a glass podium right before he had a ginormous bowel movement that made everybody stay far away from him. So you want to prevent badness in Jack. So think about that when we're thinking about what we can do to optimize TB infection treatment. With that, I will stop and I will defer to the Heartland folks. Do you want me to start answering questions in the chat? What would you like me to do?
Hey, Dr. Cruz, thank you so much for that outstanding talk. We had some questions that were sent in by some of the panel physicians. Were you able to receive those?
I did not, although I've been sleeping at weird hours for the
Not
last.
a problem. I can read them.
Oh, perfect.
And we have a notice that Dr. Cameron and Dr. John are also here with us today. So with some of the questions, I think, I'd all be very interested in hearing what your thoughts were. One of the questions so the first question, when is it necessary for a newborn to take LTBI treatment?
So the issue with newborns, so the most common reason we give treatment to newborns is because they were exposed shortly after birth to a case. And so if you're giving INH to those kids and they're exclusively breastfed, it is important that you give them B6 as well, because typically breast milk does not have sufficient pyridoxine to account for the slight depletion in stores that you might see with isoniazid. That's the most common reason we give any TB treatment to a newborn, is because grandpa was in the delivery room and then was diagnosed with pulmonary TB like the next day or something like that. And we have a low threshold for starting treatment in those patients. And what we'll often do is we'll often keep them on INH or rifampin until they're about 4 months of age, when we have a chance to skin test them or do an IGRA. Remember, you're never too young to get a test of infection, because if it's positive, it's really helpful. And actually, Lindsay can speak to a fascinating case that she had of a kid who had initially, Lindsay, please interrupt. I think the kid had a normal chest x-ray, right? And then had a positive IGRA.
No, actually, it was exposed to dad who had a positive expert, and that his initial test of infection IGRA is actually very positive.
Okay.
And chest x-ray showed some hyperinflation. So we had to get a CT that showed some hyaluronopathy. Yeah. Actually presented it in my case. So the IGRA was super helpful in him. He was 2 months old and was very, very positive, wicked positive, as Dr. Stark would mention.
Yeah, because I think one of the things is if you have a positive IGRA in a real young infant, you really have to make 100% certain they do not have TB disease, right? Because I mean, all Lindsay's kid had was hyperinflation, and maybe if Susan John had been the one looking at the X-ray, she would have been like, "Oh, you have hyperinflation because you have some air trapping because you got some nodes," right? But the initial reading that we got was that the chest X-ray was actually fairly unremarkable. So that's the most common reason we have kids on treatment in the newborn period is they have an exposure right around the time of birth, because what happens when a kid is born, everybody and their mother floods in to see the child, right?
I would add to that as well. I frequently will use that to keep the child with the mom. So if the mom tests positive for TB and wants to breastfeed, we will get the mom on treatment as soon as possible. And if there's no indication that mom has, either rifampin resistance or MDR TB, then we're really, as pediatricians, pro breastfeeding if that's what the mom wants to do. So I will, in some cases, start the baby on treatment for LTBI just to protect the child. Once again, I mean, I can't emphasize enough, the point that Dr. Cruz is making. You have to rule out active disease and not give that child a single drug. But we feel pretty confident the child does not have active disease. I will put the child on treatment to keep her with the mom. Don't separate the mommies. That's mean.
No.
So here, I think, and Dr. Cruz covered this a lot, and I think it's really important. How do we prevent failed or incomplete treatment? And the point she's made, of how difficult it is, and I think working with the family, I'll let her kind of, re-say that, but I think the points that she's making are really important.
Yeah, and usually we don't face a lot of initial hesitancy from families when they're in clinic with us. And I think in part it's because Lindsay, Jeff, and I have been doing this for a while. I think in part is, there are different demographics of your TB population, different places. Ours is a largely Hispanic population. All three, well, Lindsay speaks Spanish well, I speak Spanish, Jeff tries. So I think, there are a little bit fewer linguistic barriers for us than depending on, where you live and what languages you're proficient in. But our challenge is usually not with the kids who are exposed, because the parents have a living, breathing example of somebody in the home who is not having good health secondary to TB. The pushback we will get sometimes is in the children with, a positive quant or something like that, who has no specific TB risk factors, and a child who's been living with the parents, and then the rest of the parents and the rest of the family is all negative. And actually I had a kid in clinic on Tuesday who the mom's like, well, I know that you want to, that she had an IGRA that was, I don't know if that's Kim Smith or another K Smith 1, who asked about borderline results. And what do you do with those, right? And so we had a kid whose quantiferon on Tuesday was 0.36 and 0.57, right? I'm like, yes, they're both technically positive, but boy, that is just an anemically positive IGRA. And I wanted to make sure that this kid would have benefit from treatment. And so, Lisa, I'm curious as to what you do, but I wanted to get a T-spot on the kid. And I think the family really didn't want to treat the kid to begin with, because I offered a T-spot and the family was like, can we get this done through the hospital district, because it helped with insurance status. And I was like, I don't think the hospital district can actually do that. But Kim or Lisa, what do you do with kids with borderline QFTs? Do you do the other IGRA? Do you say I'm going to repeat it in a few months if they have no specific risk factors?
So, yeah, I mean, if everyone, I'm just thinking back to the example that you gave with the one kid that was on, that was on immune suppressants, and everybody in the house was positive. I've done the same thing you have. There's one person negative in the house, and I have a test that's not 100%. So if everything epidemiologically tells me that person is likely infected and I got a borderline, that's close enough. I'm going to treat that kid. If it's, one random hit on a kid and everybody's negative, that leans me more toward wanting to give it a break and retest, and then ask a question. Is there anything that would be driving the immune response that I'm seeing?
Absolutely. I
And
see.
so,
Oh,
okay.
sorry.
You know,
No, please, Lisa, go ahead.
no, that was I had and I wondered, so the panel physicians who are present, you know, we have a very kind of US experience, and I wonder what, you know, what the experience that they're having, and if they're getting much pushback, because, you know, we're doing a lot of teaching when individuals comes to the US, and we used to tell them, you know, you're here, the fact, you know, you're here in the US, and your chances of reinfection are much lower, and it makes more sense to, you know, to have your child treated. But, you know, I keep pointing out that, you know, they're going to be tested when they start school. They're going to be tested again when they start college. They're going to be tested. You know, if we do the treatment, this kind of quiets all of that down. But I don't know that you have that. I guess if individuals are wanting to immigrate to the US, then that might be a message that that resonates with them. But if any of the panel physicians are here, if they want to put something in the chat box about how they deal with whether parents are receptive to treatment or not, we'd love to have you share. So let me see, there's a question, and I think this is more of a DGMQ question, but it's like, is there any plan to expand the age range for IGRA testing in the US immigration medical examinations? And I think that kind of goes to the uncertainty about the IGRAs in children under 2, which is a hard kind of controversial area. And I know that all of us on the phone have kind of tipped down into pressing that a little bit on the lower end of things. Because I mean, seriously, I have a chubby 1-year-old who's, you know, smiling at me, and I'm thinking, IGRA, you know, they've been BCG vaccinated. I'm very concerned that they're going to have a false positive TST. And I still get those from refugee clinic where the entire family tests negative with an IGRA. And I have one little chubby 14-month-old that's testing positive with a TST. And we do IGRAs in those. And I don't know how low the ones on the this is, you know, some physician, you know, going to be some physician preference, but Andrea, Lindsay, and Kim, like where are y'all driving your numbers to with your comfort level?
I routinely will go down to 1. And if I'm concerned about disease, I'll do it in kids of any age.
Right.
Sure. And I think that there's also technical challenges, like that chubby 1-year-old. Wait, getting blood from those kids is sometimes like getting blood from a stone. And we are so ridiculously coddled at a children's hospital that we have phlebotomists
and
like throw like a butterfly needle from across the room and get into a child's vein.
Yeah, sure.
Whereas if I'm the one trying to do the blood draw, oh my gosh, you better have veins like Arnold Schwarzenegger, otherwise it is going to be like doomed to failure. So I think that's another consideration. I don't know, Lindsay and Kim, how low are you guys going?
Oh, it's really interesting. I actually saw a 2-month-old whose health department did a T-spot as their initial test of infection, and it was negative. He was exposed to an uncle who had cavitary TB, so was put on window prophylaxis, but I recommended they do a TST at 4 to 6 months of age, just to reliably exclude TB infection. So we put him on INH, and that I wanted a TST just because I'm not sure I can trust a negative IGRA in that age group. That kid, like, he wasn't a chunky 2-month-old. I don't know what he's going to be like at 4 to 6 months of age, but it made me feel nervous to trust a negative TST and T-spot. And he didn't live with the uncle, but the uncle came every day for 2 months for his life to have meals, and was frequently coughing, and then developed hemoptysis. So it was a true exposure. The uncle was smear negative, but it seemed like definitely a significant disease. So
we had to go back to, we tried in our clinic, and after traumatizing many small children and traumatizing ourselves in the process, we had to work it out with refugee clinic that was drawing bloods for lead levels and CBCs and things on the intake, and asked them if they would do the draws for us, because we couldn't do it. I thought after, like, I don't know, therapy dogs and hugs for my nurses who were the ones who were trying to do it, we finally had to give up. So that's not a trivial point. Hi, Dr. Smith. It's good to see you. I'm glad you were able to join us.
Hey, Lisa, it's Kim. Are you talking to me, Dr. Smith? Or are you talking to?
No,
oh, okay.
Kim, just wanted to say hi.
Hi. So Abby and I are here together. We've been listening to this wonderful talk. I think it's tricky. I feel comfortable with IGRAs, even in really small infants, if we're trying to look at disease for sure, because I think all the information you can get, I think a TST and an IGRA, even sometimes I'll do a T-spot and a quantiferon if we're just trying to sort things out. And then I think I wish we had better guidelines, but I always hate to put a TST on a kid that's 6 months old that's had a BCG, because I'm just pretty sure it's going to show something, So I really personally I think we'll eventually get to doing IGRAs in all these BCG vaccinated kids, but I feel very comfortable in kids a year, down to a year. And I really think we're going to move towards the younger kids too.
And I think that, when we're in our TB clinic, we have the luxury of time to really dive into risk factors with families in a way that my community pediatric colleagues do not, because they're seeing 40 to 50 kids a day, which like the thought of actually doing that is frankly terrifying to me. So what we do as a TB community might actually be different than what's done on national guidelines, because we bring different expertise to the table. That's the first point. The second point is I actually wanted to emphasize a really important point that Lindsay made about that uncle, right? We always use the example of the uncle, right? But, important to realize, people can be a household contact and not live under the same roof.
Yes.
Right. So if baby's cared for by grandma at the house every single day, just because grandma's got a different street address, grandma is a household contact, right? That uncle is a household contact, even though he has a different residence, right? So important to dive into not just what is the familiar relationship with a kid, but how much time does that person spend around that child, right? Because we've had times when, you have the grandfather and only one of the kids in the household is infected and everyone else is negative. And you're like, what happened to poor Johnny? How come Johnny's got a positive IGRA? And it turns out it's like Johnny's the one who sits on grandpa's lap when they're watching boxing. You're like, that explains it. And then there's some times where it's like, it's the kid who really doesn't like the grandfather. And you're like, oh, now I'm just mystified, right? But really kind of diving into those familiar relationships and where do kids spend time is really important. In part because if you're going to be doing winter prophylaxis or you're going to be doing treatment for infection, the health department's got to know where to go to find the child, right? And so if the kid ain't the home address all day, putting the home address doesn't make a lot of sense. And you need to write where, especially if they're in different jurisdictions, right? We have so many jurisdictions that cover the greater Houston area. It was really important for us to know because the kid might live in one jurisdiction and spend time all day during business hours in a completely different jurisdiction. And it requires coordination of resources.
Right. And I would say to the panel physicians that the epidemiology around the child is really important. So if you have a child and they're required testing for immigration and you still have some concerns there, the parents have tested positive or there are other individuals around the child who are tested positive or have known active disease and you get a negative IGRA, I would still be suspicious. I would still consider doing a thorough exam or having the child referred to a pediatrician as being a very close and strong contact before you just kind of give up on that. The tests are not 100%. Let's see, here's a question. What is the efficacy of the LTBI medications? I think, Andrea, did you have a slide on that?
I did for some of this, for some of the individual regimens. So probably the best data on this are from Catherine Sue, who did like a 30-year longitudinal follow-up. And I know that the data for adults are that there's about a 7% failure rate for LTBI treatment. It's 7 to 9%, I think. It was the last data that I saw. We have seen, and Lindsay, if you've had a kid, please correct me, or Kim and Abby, if you've had other instances. So we've only had 3 kids that I know about who were prescribed, not necessarily took TB infection treatment and then developed disease. 2 were adolescents who admitted to cheeking and spitting out the meds. One of those, I presented her case earlier. And the last was actually a young child with sickle cell disease whose uncle was staying with them and actually ended up dying of TB or of HIV associated TB. And that kid, I legit believe actually took her meds. But she also was not a normal host, and we don't have a lot of data on the degree to which the spleen actually helps with clearance of TB. But Lindsay, Kim, Abby, other cases that you guys have had?
This is Kim. Abby and I are looking at each other. I don't recall any of our patients that we've been notified about or that we've known about developed disease that have taken their LTBI treatment. And we're like you, we do DOT or DOPT or ESAT on everybody we can.
Yeah, the same, Andrew. There is an important question, I think, in the Q&A that's pertinent to that. So this is from Mary Minix. If a child was treated for TB infection in a high burden country, Honduras, as a 1-year-old, but doesn't have documentation, but mom is reliable, stating that one day for every day had crushed pills for 6 months, and that this child immigrates as a 6-year-old, would you retreat if asymptomatic and has a normal x-ray due to concern for possible reinfection in such a high incidence country through immigration and transport?
So there are circumstances under which I will treat a child more than once. It's pretty rare. It's usually in children who are either incredibly young when they were first treated, or children who are immunocompromised and have more than one documented exposure. That's been the times I've treated them, and and this falls into that really unsatisfying bucket of expert opinion on like the hierarchy of data, and I totally admit that, and we're kind of winging it to some degree. We find it's if they have a defined second exposure, again, that's often not a family that you need to fight an uphill battle on why the kids need treatment. The other thing is, if they tolerated meds well once, the likelihood they're going to have a problem taking their medicine. I mean, yes, some reactions are idiosyncratic, but they're probably going to handle taking medicines okay a second time. So I've done it a couple times, but I think it's almost exclusively, I don't know what you guys' opinion is, been in immunocompromised patients who have defined exposures.
And what about 6 months of treatment of INH versus 9 months? And she was 6 months of age when she got the 6 months too.
So, I mean, for me, if the parents can give a compelling history for this, I mean, I think we should all view this through a prism of a little bit of skepticism, just because we have not made very many inroads into the treatment of TB infection in Central America. So, I would ask questions about, what did the pill look like? Was the kid peeing orange or not? That's like my favorite question, try to determine what the kid might have gotten in the past. I was like, were they peeing Astro's orange? Or were they peeing Astro's orange? And,
You know what, Andrea, I take one step further than that. I asked them, did the urine turn a different color? And I don't give them the color.
Oh, yeah, good.
Yeah.
Totally stealing
And if
that.
they say purple, you're like, no.
No, or blue, or
LSU fans.
little yellow. So yeah. And and to your point, I just, right before we started the webinar, I had a patient come in. She's in contact with her uncle, and we got the history from mom. Mom had TB, and she said they treated her baby, but she said they didn't test her. They just treated her. Mom had, smear positive TB disease, and they were in Mexico. And so I guess they knew, like we knew, if you do a skin test, the baby was likely going to be positive anyway. So they just treated. And she said she crushed the pills. And I asked the mom, did your urine turn a certain color? And she pointed to, we had pointed to the red, reddish color on our scale. So I'm like, okay, I'm feeling good about that. But she's 3 now, and she's been in the house with her uncle who's smear positive. So we're absolutely going that route again. I don't trust her 6-month-old immune system to have been stout enough to protect her from that. So in that case, we're retreating. And I wanted to read something. We have one of our DGMQ colleagues, Kim Skroboshek, says that if you have a child less than 2 who is symptomatic, you can either do an IGRA or TST along with a chest x-ray and sputum specimens, but let clinicians use their judgment for their specific patient on what test to use. This can be affected by regulations within their specific countries. So that was for the panel physicians. So that's the DGMQ recommendations for that, on whether the question of whether you should treat, how you should screen a 2-year-old, a child who's 2-year-old or less.
And I think, Kim brought up a great point with that, we will often send both IGRAs in a child with possible TB disease. I don't know about you guys, but we've had the experience at TCH where, and this particularly is the case for kids with TB meningitis or miliary disease, where you'll get a skin test at 0 millimeters, you'll get a quantiferon that's indeterminate, and you'll get a T-spot that's really positive. Like, we've now had that happen in several of our TB meningitis patients, and I know the national recommendations say that you can use the IGRAs interchangeably, but I think there are certain circumstances where you want to cast the diagnostic web broadly. Because the reality is, with TB cultures being so slow to grow and expert not being super sensitive in kids and being challenging to get in many places that are low burden settings like ours, sometimes the first indication that this is actually TB comes from having a positive IGRA. So the place where you want to cut costs is not on the kid who's like infarcting because they have TB meningitis. For the love of God, send everything in your diagnostic armamentarium in those children.
And here's one. What is your opinion on performing an IGRA after obtaining a positive TST on a child who had a BCG vaccine? Every day.
Every day.
Every day. All the time. That's the kid I want to, hopefully I'd love to get the IGRA in the first place, but if not, then yeah, absolutely. And without qualm.
And I would add to that, this is Kim, I would add to that, that in our clinic, when we first started using IGRAs, most of the community physicians were still doing TSTs. And we would get the kid referred for a positive TST. And we would do an IGRA just to confirm it if they had BCG vaccine. And it really reduced the number of kids we had to treat by around 20 to 30%, because many of them were what we considered a false positive on their TST, and their quantiferon or T-spot was negative.
And these are in kids who don't have a specific exposure, right? I mean, if mom has TB, like any test being positive, just call it a day and treat them, right? These are the kids who, were born in Mexico, came to the US years ago and have no other specific risk factors. And actually came in our place, we found that it's like over 50% of the time, the IGRA is negative. So we have really been able to reduce our treatments, so much so that right now we routinely ask our community providers before they make a referral, they get this skin test. That's of course 10 millimeters, right? Because it's always 10 millimeters. And we're kind of like, we are happy to see the child if they were to have a positive quantiferon. This is the lab code for ordering in Quest. And, so many of the times, they get that lab through their pediatrician. It saves them an x-ray. It saves them the cost of an additional, visit to see us. It's just a real family-friendly approach.
When
We do the same.
Yeah, I sat on the DGMQ committee that was looking to change the guidance. And I pointed out to them that everybody has a 10 millimeter TST, like everybody. Like it's never 11 or 9, it's always 10.
Yeah.
And so
But if they do have a 10 centimeter skin
that joke
test,
kind of ran through with us. 10 millimeters.
Yeah.
There were a couple of questions I wanted to run through real quick. David Holcomb asked, your civil surgeons are all foreign-born applicants, including children, are they obliged to report positive IGRAs to your health departments? And the answer is yes. So they just wanted to put that. And then add a couple of pregnant lady questions real quick. What is the best treatment choice for pregnant women with LTBI? I'm still going to go with rifampin. In addition to, we don't have as much toxicity in children, and Dr. Cruz went through an outstanding kind of review of what we know about the medications in children. But in the pregnant ladies, there is some question around isoniazid. There's a tendency to see higher levels of hepatotoxicity in kind of postpartum, especially during the pregnant and postpartum periods. If you're going to watch the lady, it's a safe drug, but you have to keep very close attention with the ladies. We don't have as much literature where we were with children just a few years back. We don't have literature on rifampin in pregnant ladies, but what you don't see is case reports and studies that are showing that there is increased toxicity. So the 3-HP is not recommended because it has not been studied at all. All pregnant ladies were excluded from the study like they were serial killers or something. So I would say rifampin is probably your best bet. And if you can't use that, isoniazid would be with a very close watch. In pregnancy in the first semester, a contraindication for initiation of latent TB. Your pregnant ladies in the first trimester frequently are trying to work out the nausea and morning sickness, etc. So you may want to wait if you can, wait until they're through the first trimester. But if they're a close case to a close contact to an active case, then you're saving both that lady and that baby. I would say, try to work out something for nausea and get her on the meds. And should IGRA testing be obtained in adult patients with suggestive chest x-rays, or rely only on the stains and cultures? I don't think the DGMQ requirements are that you have to get an IGRA. We do in the US. I would strongly recommend it. If there could be other things that are causing abnormalities in the chest x-ray, but if you have a positive IGRA and abnormal chest x-rays, then you want to get stains and cultures and probably give you more information. So those were the additional questions I want to check.
Lisa, there's a question in the chat as well. It seems like rifabutin is also getting on short supply. So Ellen is saying they're being told to use 3-HP or INH in those women.
Right. And the state of Texas, I know we're having that. We're having, one of our states in the Heartland region had every rifamycin go on shortage. So that was really, yeah, all of them. So that was a scary place, especially in patients with active disease. I think we're trying to wait for some of the supply chain things to unkink themselves. I don't know if y'all know this, the largest suppliers of rifampin are out of Italy and India. And when we had our biggest hits on COVID, it was Italy and India. So you're seeing things try to ramp back up, but I think we're all kind of having to scramble a little bit. I would say that isoniazid has been used for years. We know that, there's the hepatotoxicity and fulminant liver failure. The thing is communication. If you're going to put your patient on the medication, watching over them and having some means for them to contact you if there's a problem, and letting them know stop the meds if you have any problems. I think is going to be the biggest thing.
Kim, I think I speak on behalf of all the people who are straight peds when I say how grateful we are that you answered the question on pregnant people, since frankly, pregnant people completely terrify me from a medical standpoint.
There was a question about gastrics, and that's I'm glad we'll go with that one, because Dr. Smith and Dr. Geltmeyer are going to be addressing that in the next webinar on treatment.
Any comment? I have a question about it. The old school was if a woman's pregnant and she has LTBI to wait on treatment. If she's healthy and not a recent converter, is there any reason why you wouldn't wait besides just lost to follow-up?
I think we started a conversation in our region because we were seeing a lot of pregnant ladies that were screened. The whole family gets screened, all of the children get put on treatment, the dad is on treatment for LTBI, and then the mom waited. And then we're seeing either the mom break down with disease shortly after birth because her immune system is doing a little kind of a juggling thing, or we've had a lot of women who came back to get treated and then were pregnant again. So that kind of delayed treatment further. And then we had one who was pregnant with active disease. So we started to kind of rethink things. The national guidance is still just to wait, but really, you're putting 2 lives at risk. So we're starting to have some more national conversations and looking at a lot of the women who are at greatest risk are immigrating over from other countries. It's very stressful. I spent 6 weeks in Mexico and understood some Spanish, but just understanding where to go to get your groceries, how to get from one, point A to point B. If you have any other questions, understanding how to, there's only so much that little kind of hand. And back in the day when I went, okay, yes, I'm dating myself, but there were no apps on your cell phone to translate for you. So I was having some concern. It was only for 6 weeks. And I knew that there was a short period of time. And I knew where there were individuals who supported me that spoke English. But it's a lot of stress, moving to a new place. And we're finding that, individuals were screening folks, and it feels a little kind of not as sensible to sit on a woman who potentially could infect herself and her baby and not offer treatment, especially when it looks like the newer treatments are a lot safer. So
and so many women have access to care when they're pregnant, and they so rapidly lose access to all care in the postpartum period, that I think when we think about, we'll just wait, then I think that's predicated on an assumption that they're going to have equivalent access to care in the future they have now, which might very well not be accurate.
Good point, especially in Texas.
Mm-hmm. Dr. Skrbishek says that IGRAs are helpful, but cost comes into play overseas as well. Quantiferon costs $200 in one country we recently evaluated, so that can be a barrier to getting them when they aren't required. So.
Mm-hmm.
I think, we all, can say, that, we're looking at the best options, and they make sense, except if you can't afford it. So.
Speaking of immigrants getting IGRAs, we've had a large influx of immigrants recently, and the paperwork, it just says IGRA was positive.
Yeah.
And it would be so helpful to actually get the numbers, if that's at all possible, because we like to look at the actual numbers on the IGRA.
We've been noticing that too, Kim, and in some of those that have no TB risk factors, and depending on the situation, I actually repeat them to see if they're actually in fact positive prior to starting treatment, especially with the rifampin shortage. But in those that have obvious risk factors, then I just trust it and treat.
Right. We've also had a couple that had, it said IGRA was positive on the result, and we had the report, and the numbers were actually not positive.
Oh,
so
wow.
That was confusing to me as well, but we've seen that twice.
Yeah, because they don't have to actually subtraction. Right, the antigen minus the nil isn't subtracted, that you have to do it. Yeah, we've seen that too.
Yeah, it's particularly, I think it's what, Lindsay, LabCorp that is now doing that they'll give you the nil, and then they'll give you the TB 1 and the TB 2, but they don't subtract them out.
Right.
Especially if they're borderline, once you subtract out the nil.
Yep. And you can see that one's positive, the other's negative. So if there's discordant IGRAs too, I'm doing those, especially if they're really discordant, like one's super high and one's negative, then I'm repeating those as well. And those that don't have risk factors. Yeah.
We had one of those recently, and we've also seen some labs are now reporting out the TB antigen minus the nil, and they're giving you that number, whereas the old way it would come out would, you had to do the math yourself. So you really have to look at it carefully to interpret the test.
Right. And then Rebecca Muniz pointed out that she has had she's had a case where they had a negative IGRA, but had smear positive TB. That I think my understanding is that we're still, the thought is that the IGRAs are still about like the TSTs. About 25% of the time when patients with active disease, you will have a negative screening test. If you rescreen after 2 months, generally you will see, that the response will rebound, and you'll frequently get a positive test. But I have a little list of patients in my clinic that, and then they're none of my children, but all adults, because they're culture positive. So, all my adults, but they just remained, and the nurses are just like, they're determined they're going to catch that response. And T-spot's been negative from the start of treatment to completing treatment. That was like their parting gift. Let me just draw this one more time, but the tests are not, there's no test that's 100%. Like we don't have 100% sensitivity, nor do we have 100% specificity. So you can get some false positives and some false negatives. You try to put your data around the patient together as best you can, but I think all of us have stories.
It's a little bit maddening. I'm wondering if anyone's working on a test of cure. I would sure like to have that.
Okay, so it says when panel physicians use e-medical, which is the electronic record submission, the quant values are required. So hopefully that will cut down on some of these issues of non-reporting.
Oh, cool.
Because I've gotten a couple of those too. So we're looking forward to that, the positive. Sometimes we just repeat, a T-spot, which seems kind of, or repeat an IGRA once they come to our clinic, which, kind of defeats the purpose. But if I have some question, again, everyone has tested negative, and I have this one kid. And that could be the one kid that was either, like you said, at grandma's all day and hanging out with a really fun aunt that, had a cough, or could have been anything. But it's really hard for the parents, really feel like, it's always odd when you have a 2-year-old and a 3-year-old, and one tests positive and the other one doesn't. And they're like, like a unit. They are one unit of activity and child, and they're together all the time, every day, and sleep together. And
that's when you realize who grandma loves the most.
Okay, I'm trying to make sure we got it. And I want to thank Dr. Mutimbi He said, we have a big challenge here in Gabon and the Central Africa in child TB. Our IGRAs or TST are not frequently implemented by practitioners. Also, it is difficult managing TB and HIV both in the same child. Agree, it's a challenge in adults as well. But hopefully, isoniazid is the answer in that case. You know, it's the one time when I would say that it doesn't interfere with most of the medications you want to use, but I guess just having some access is complicated.
Lisa, there's an interesting question from Becky Smith in the Q&A. It
Mhm.
says, what's your opinion of a low positive quantiferin at 0.38? She only gave one value, not multiple, on a person being tested for administration of immune supplements. And due to low positive, ordered a T-spot, and that was negative. I assume it was both tests were done prior to immune suppression, but I can't say that with certainty. And she didn't mention risk factors.
Those
So-
are hard.
Those are super hard. I mean, I think in a child, in someone that has any obvious TB risk factors, then you treat, and I wouldn't have even done a T-spot because even a low positive is concerning. And in a lot of those kids, they're already immune suppressed even prior to them getting immune suppression, which makes them even more immunosuppressed. And then you further can't trust the tests of infection. So those kids scare us a lot. Yeah.
We do the same, adults or kids, if they're even with a low positive, if we're about to give them a biologic, we just treat. And
Yeah.
even if I have 2 or 3 tests and one of them is positive, I usually take that one positive and I treat.
Yeah. Andrea, I don't know if you want to talk about our experience of what treatment we often recommend in those who are about to start a biologic, if you want to comment on that or.
Yeah, so I mean, I agree. You know, for us, the perfect time to get the IGRA and the TST is before they're at all immunosuppressed. Whereas, you know, it seems like it's often, oh crud, they're about to need infliximab, and I need to get this, and then they're already on systemic corticosteroids and stuff. I think oftentimes it depends on which immunosuppressant they're going to get. I think, you know, there's some that do interact with rifampin. We, again, falling into the bucket of expert opinion. You know, what we said when we were using predominantly INH as the primary preventive treatment was that it would be ideal if the kids got at least a month of meds on board before they started their immunosuppression. That is sometimes, it's, you know, it's easy if they're on immunosuppression for like a dermatologic condition that is more, frankly, and I don't want to minimize the bullying that these kids sometimes face, but if they have linear morphia and they have like some, you know, some funny rash on their belly that is otherwise not causing systemic symptoms, I mean, it's not that I don't care if they wait, because I'm sure the kid doesn't want to have that rash, but I'm a little bit less worried about the child waiting. If it's a child with Crohn's disease who is having bloody diarrhea and is pooping their brains out, and they're going to withhold a therapy that is going to dramatically include that kid's quality of life, you know, usually I'm kind of like, we want the kid to start medication after we rule out disease. We would like them to get as much as the medicine as they can before you start them on their biologic. But if they're pooping their brains out with bloody diarrhea 14 times a day, the reality is you can't really wait, right? So one of the questions that we've asked ourselves is, well, if a month of treatment seemed like it was adequate when it was INH, and that's about 10% of the dose, if you're using a shorter course regimen, like let's say they're going to be on some medications that don't interact with rifampin, and we have rifampin available. Like, how much rifampin do you need to give? Because my God, they're all going to be getting a 4-month course anyways. So, you know, do you need to give them a couple weeks, whatever? And the same thing with the INH and rifapentine. For those kids, if we can get that on board quickly for the kids. But typically what we've been saying is, you know, we'd like them to get as much on board, but if the kid's absolutely miserable from their underlying disease process, you need to treat their underlying disease process. Is Kim, Abby, is that what you guys are telling them?
Yes. And I've had a couple too where they were already on immunosuppressive for quite some time, and they were doing their, you know, every 6-month or every 12-month screen. And the kid comes up with we had one that had just like a T-spot test that was maybe 8 spots or something. It was really low positive, but the kid had questionable chest x-ray, and it was just, you know, it was just one of those where you just have to go on that side of treating because they're immunosuppressed and you don't want to risk it.
And we do that too, Andrea. We, you know, if they can wait a month, then we do a month. But if they have something, you know, I'm always worried about like eyes and joints. If there's going to be irreparable damage, then we start the treatment as soon as we can, but we don't withhold the biologic, or the same thing patients with cancer. And I wondered, I had a question, like while we have the panel physicians on, if they're screening a child overseas and they have a positive IGRA, more than likely they're going to travel soon, then we will deal with that when they come here. But what are your thoughts about starting treatment overseas? If it's for example, if the child has LTBI because the parent has active disease and they're treating, but the child's what would you think about them starting treatment there versus here? Would you rather they just send them to you, or would you rather they start treatment there?
Lindsay, Abby?
Yeah, I think the number one depends on the age of the child, right? And what the delay is going to be prior to immigration. If the child is less than a year and is infected, obviously you have to exclude TB disease in that situation as best as you can. But even those less than 5, I think I would be more eager to treat, especially if there's going to be a delay in immigration.
Right. You're going to be there 4 to 6 months. It might be best to
just start. Yep.
And I don't know who I have issues with liquid isoniazid with children due to osmotic diarrhea it causes in the question and answer, but we're saying that we're in solidarity with you. We do too.
The only parents who like that are the ones whose kids have constipation, because that's where liquid INH is better than relax in terms of getting those kids regular.
That's funny.
Andrea, what do you think about using a tablet that's crushed in those that have breasts that can have express breast milk or formula, like a 2-month-old that can have a dose of INH twice a week? Are you okay with doing that?
I'm okay with that. I think it's one of those issues that you have to make sure that give very explicit mixing instructions to the parents. Because sometimes, if you crush it and you put it in a whole bottle, like how much of that stuff's being caught up in the nipple of the bottle. So theoretically, if they were going to do it, I would say it'd be nice to crush it and then mix it with something like express breast milk and then use a syringe to squirt it in, because then you'll at least have a sense of how much residual do you have in the syringe.
Yeah, I did that in a 2-month-old. The 2-month-old that's actually exposed to her uncle. She was 5 kilos, and I could do 150 milligrams twice a week. So the health department's helping.
Yeah, and in those kids, what I'll often do is, because the kids gain weight like gangbusters at that age, so I'll often give them a higher dose, because if it's a month before you see them back, I'm amazed at how especially breastfed babies just pack on the weight, and I see them back and I'm like, oh my god, you're up 2 kilos. And it's like normal baby growth for a breastfed baby, but so I try to go on the higher end of the dosing interval so the kid can grow into that dose. I don't go on the lower end, because then the kid doesn't, just like Lindsay did, she put them on the higher end of the dosing interval so that they have a chance to grow into that dose.
So here's one. So what are some considerations you take in for the families when providing window prophylaxis? So if a panel physician does diagnose an adult in the house with active disease it has an infectious individual in the house, then you have a child, how would you counsel them on treatment with window prophylaxis?
Abroad or domestically?
Abroad. I'm thinking this is one of our panel physicians, but I may be wrong. In the Q&A.
Oh, I'm in the wrong screens.
Okay.
I don't see the question, Lisa.
And as I said, the last question is about collecting sputum versus gastric aspirates in young children, and we'll cover that in our next webinar.
Lisa, do they have access to window prophylaxis in most countries internationally to be able to administer to young children?
That's a good question. And that I'm not sure.
I mean, I think, it depends, right? If the parent has MDR, you're kind of between a rock and a hard place, right? Because on the one hand, my God, that's really the kid you want to prevent from progressing, right? And on the other hand, sometimes you need to know your second line drug susceptibilities. There's a lot of data that you need to have at your disposal so you can select the right drug for the kid. So, I mean, I think, again, we have the luxury here of, I'm worried about a kid, Lindsay and I have a kid that we have together who's got real complicated Mycobacterium bovis, and we were able to get her isolated over to Bev Metchcock's lab, and Bev's going to do second line susceptibility testing for us over there, right? Or the CDC lab is going to be able to do that. And that's not something that's available everywhere. Like, for example, when I was in, I think it was when I was in Malawi, that they actually send their second line drug susceptibility test to South Africa to be run. So, sometimes, if it's a patient with MDR, you might say, this is a kid I really want to treat, and you might not have all the data at your disposal.
Yeah.
Being able to know what drug to select. If you have access to it, I would say the philosophy would be very similar to the same conversations we have with our families here. And again, usually that's not the families in whom we get pushback. I think that is an important conversation to have with their clinicians, though, in those countries, because if there's not a culture of treating kids for prevention, again, it's then what if clinicians always been taught you never treat TB with one drug, right? So
Right.
you need to explain why this situation is different, so that kid's regular healthcare provider is not like, what on earth are you doing? Like, why do you have this kid on just one drug? Like, kids, people with TB are always on multiple drugs. It's
Right.
important to carve out why this population is a little bit different. And important to also remember the WHO guidelines that if you have a kid under 5 who's in a home with a case, then you don't even need a test of infection. They just recommend you give the kid INH.
Right. And there's one of our panel physicians says, I'm a panel physician in Tanzania. And doctor, I'm sorry, I don't want to butcher your name, but it says if a child is contact and has a positive IGRA and active TB has been ruled out, the child will receive treatment for latent TB, which is 6 months of isoniazid. And this depends on the country TB guide. So thank you for sharing that.
Thank you.
So I think I've exhausted all of the questions that I can find that we had. Let's see. We got the pregnant lady questions in there. There's a question about what to do in IGRA shortages. Honestly, I let DGMQ know. I would be calling DGMQ and letting them know, if you can't get a hold of the test. And I think there's probably some contingency if you're not able to get the required test for the evaluation, but that's a little bit beyond what we can do here. And I think we've covered everything else. And we've run through all of our guides and questions. So Chelsea, do you want to close us out? Oh, here we go. This is good. Yes. Report IGRA shortages to CQAP@cdc.gov to troubleshoot. So that's from our DGMQ colleague. And I want to thank Dr. Skrobershek for coming on with us and answering all of our DGMQ questions. And I really want to thank all of our panel physicians for taking the time to join us wherever you are in the world.
Thank you guys for inviting us and for hanging out for 2 hours on a Thursday afternoon.
Okay, well, I want to say thank you so much to our panel physicians. It was another great webcast.